Good afternoon. I am Dr. Vinod Malik, Co-Chairman, Department of Laparoscopic and General Surgery at Sir Ganga Hospital. I welcome you on behalf of ASI to this webinar on intercostal drainage. Chest tube insertion is life-saving basic surgical procedure. Though a simple procedure, there is a need to standardize it so that patient gets an optimum outcome and complications are kept down to minimum. When to do it, how to maintain it, when to remove it safely are important aspects of chest tube drainage. To talk to us about all this is none other than Professor Arvind Kumar, Director of the Institute of Chest and Robotic Surgery at Sir Ganga Hospital. He is former Professor of Surgery at All India Institute of Medical Sciences. Last but not least, he is the President of Association of Surgeons of India, and the topic of patient safety is very close to his heart. His greatest contribution outside his specialty of chest surgery is adoption and popularization of WHO safety checklist. He is country's foremost chest surgeon with a vast range of open, laparoscopic and robotic surgeries. His agreeing to talk on this subject shows how much importance he accords to this procedure. Over to Professor Kumar. But before we hand over the mic to Professor Kumar, I have to say that we will have a question answer session at the end of this program, and Professor Kumar will be very happy to take your questions, comments, and clarifications that you may have. And we have this number, which I would like you to note down. It's a WhatsApp number, so you can put in your queries on this number if you have one, and this will be taken up at the end of the program. The number is 958-1599-918. I repeat, 958-1599-918. And this program comes to you through the generous contribution by Healthium. Over to Professor Kumar for his covering up the topic of his great experience of more than 30 years of practicing chest surgery. Professor Kumar.
Thank you very much, Professor Malik. First of all, my humble and sincere thanks to you for agreeing to be a moderator of this seminar. I know how busy you are, and still you've agreed to take time out of your OPD time and be with us for the next 1.5 to 2 hours. That's very kind of you, and my humble and sincere thanks to you. On behalf of Association of Surgeons of India, it's my very pleasant duty to welcome all the participants from across the country. I extend a welcome to all our members, non-members, faculty members, residents, and a very, very warm and very, very special welcome to physicians, pulmonologists, and pediatricians who have also joined this program. So on behalf of ASI, a very warm and special welcome to all of them. My thanks also to Healthium for starting this initiative. This initiative was started just 2 months back. This is the third program, and this program has been possible because of 2 persons, and I must mention the name. One is our ASI's website secretary, Dr. Shivaram, who's watching us from city of Bangalore. Dr. Shivaram, this program has seen the day of light only because of your efforts, and equally importantly, it's been possible because of the generous support from Healthium company. Now, as you all know, Healthium earlier used to be Suture India Limited, but by Suture of India Limited merging with 2 more companies, we have this new company called Healthium. And I would like to make a special mention of the young, dynamic, and energetic new CEO of this company, Mr. Shirish Bafna, whom I met, Anishma, my apologies, Mr. Anish Bafna, whom I met at Bangalore just about 15 days back. And I was really very happy at the vision that he has for the country, for this company, access to precision medtech for every patient globally is the vision of this company. And when he mentioned that he's working towards making Healthium the largest Indian medtech company, I think it was really a matter of joy. On behalf of ASI, my sincere thanks to Mr. Bafna and to over 200 colleagues from Healthium across the country who have arranged the programs to be telecast at all the centers. With that introduction, now why did we choose this topic? Safe chest tube insertion is a very basic kind of topic, but friends, working in the field of chest surgery for last over 30 years, I have come across every possible complication that one can have in the chest while people were inserting chest tube. It's a very simple procedure, very basic procedure, something which is just like tracheostomy. It's not a chest specific procedure. It should be known to every doctor. So therefore, we thought when we are starting this new webinar series for people from across the country, we should start from a topic which is simple and which will help a large number of people. But before I move on, let me have the pleasure of extending you greetings to across the country from All India Institute, which was my previous institution, and from Sir Gangaram Hospital, which is my present institution of working. The various topics which I wish to cover in the next 45 minutes quickly is indications for chest tube insertion, how to insert it safely, the various drainage systems available, how to maintain this tube, what are the indications when to remove the tube, how to remove it safely. Sometimes some problems occur post chest tube removal, how to tackle those problems, and some special situations like loculated effusion. And about 45 minutes later, I would end with last two slides, which will be the take-home messages as far as these topics are concerned. So coming first to indications, it's indicated when you have air or fluid or a combination of the two in the chest cavity. So pneumothorax or tension pneumothorax is when you have air in the pleural cavity, or when there is fluid like pleural effusion, empyema, hemothorax, chylothorax, or a combination of the two, that is pyoneumothorax, hydropneumothorax, hemopneumothorax, which could be traumatic or secondary to surgery, etc. And some special situations like following a cardiac surgery, chest surgery, mediastinal surgery, any pleural surgery or esophageal surgery, in a post-pneumonectomy situation, and in cases of bronchopleural fistula, or when we have treatment with sclerosing agents or pleurodiscs is being done. So these are various indications when chest tube needs to be put. Now, when you decide to put a chest tube, it's important that a consent is taken from the patient. After all, it's an invasion on the patient's body, and sometimes I have seen consent not being taken. So in today's era, it's absolutely vital that you take consent. One. Next, it's extremely important to explain the procedure to the patient. Time and again, I have seen that what is going to be done is not explained to the patient. They're just told, oh, some tube will be put, and patient has a lot of apprehension. They face more than what they expected, and at the end you have an unhappy patient. So it's important that you explain to them what exactly you are going to do. Trust me, it goes a long way in getting you cooperation from the patient during the procedure, and at the end it leaves a satisfied patient rather than an unhappy complaining patient. It's important to have a quiet patient, and therefore it is advisable that some kind of a mild sedative may be given, especially if the patient is extremely apprehensive. It's vital, and I would repeat, it's vital to have an intravenous line or at least an intravenous access available, because anything may happen while the tube is being put, and if there is a mishap, there is a problem, there will be no time to get an IV access. If the patient has dehydration or hypovolemia, it's better to correct that before you start putting. Otherwise, you'll have more problems at hand. I generally have oxygen on flow on these patients, but it's important to have a pulse oximeter in place, and if possible, another person available who can be actually looking at the pulse oximeter. An often asked question is, who should put this tube? Well, to my mind, chest tube insertion is a basic procedure. Every doctor should be able to put a chest tube, just like starting an IV line or doing a tracheostomy. But that person must have some experience and should be aware of the steps. If not, he should be assisted by somebody who has an experience. Another thing is that while you are doing it, even if you are experienced, it's always better to have another pair of hands available at the side. It could be your resident, it could be your another doctor, it could be a nurse, but another pair of hands available so that in case there is an issue, you have somebody to help you. It's important to have a checklist available. So chest tube, a spare chest tube, the chest tube bottle, ICD set having instrument, drape, sutures, analgesics. There should be a checklist and you should have checked all these things before you actually put an incision. Oftentimes we give an incision, then we suddenly ask for the chest tube. By chance chest tube slips from your hand, it falls on the floor, and then another one is not available. You have your artery forceps in and then you are waiting. So these kind of unpleasant situations can be avoided if we have a checklist kind of approach. Check everything before making a cut on the patient's body. It's important, vital, that we auscultate the chest carefully before we insert the tube, because after insertion you will auscultate again, and comparison is the best way to know what has been the result of your chest tube insertion. Chest tubes are available in different shapes. So they are available as simple tubes, as you would see on your screen. On the in the middle, second from the left, is the most commonly used straight kind of a tube. On the extreme left is an angled tube. In the middle is a Malicot, which I have shown only to say that today, when these kind of tubes are freely available across the country, I hope they are available at most of the places. So there is no need today to be using a red rubber Malicot catheter. On the right hand side are what are known as the tubes with trocar, or trocar chest tubes, and they are called. Now many people use this trocar chest tube and they say that it's actually safer because you have a more controlled kind of an entry. But trust me friends, I have seen more complications with these trocar chest tubes than with the standard chest tube. So my humble suggestion would be to use the straight simple chest tube, the one you are seeing on second from extreme left. The angled tube are actually loved by cardiac surgeons and they often use it after cardiac surgery. Often asked question is about the size of the chest tube. Now please look at the bottom of the slide. Smaller the chest tube, less the pain it will cause, because after all the chest tube is there is passing through your two ribs, between the two ribs, and chest tube is growing. So it's actually touching the nerves there. It does cause pain, and therefore smaller the chest tube, the better it is. Usually in adults we use about 28 or 32. It will also depend on what you are draining. If it's a clear fluid, if it's air, smallest size will do. If it's clear fluid, even a smaller tube will do. But if you have a lot of thick debris in the pus or blood is there, maybe a larger size chest tube. The general rule, around 28 size in adult males, around 24 size in adult females, about 16 size for children, and about 12 size for newborns. But this could be various. But remember, smaller the chest tube, less will be the pain. These are the various chest tubes available. Now this is what I call a procedure set, which should be available. As you would see, starting from the left, it has a sponge holder, it has a scalpel handle with a 15 or 11 number plate, it has two long artery forceps for insertion, it has a tissue forceps, it has a needle holder and suture cutting scissors, and last but not the least, most important, it has a skin fixation suture, which should be preferably a number 1 silk on a curved cutting needle. Now, this is the part which is often missed. You have all the instruments available. You put the chest tube. When it comes to fixing it, suddenly you realize, oh, there is no suture in the ward. So then the nurse goes running to the OT to get it, or she gets a suture with a round body needle, and then you are struggling to put it through the. So it's important to have this checklist, and a curved cutting needle will help you in fixing it properly. A very important slide. Where should it be put? When I say where, there are two wheres. One is location in the ward, in the OT, where, and site is the site of insertion. Now let's come to the first issue, that is location. Whether it should be put in the ward, in the outdoor, in minor OT, major OT. Now let me tell you that chest tube being inserted in the chest has as much chance of introducing infection in the chest as you would do when you operate on a chest, because you are invading and you are going inside the chest. So to my mind, the aseptic measures which need to be taken are the same that you would take when you are doing actually a procedure. Now, so my humble appeal is, whether you do it in the ward or you do it in the OT, please give it the importance. Please give asepsis the importance that it deserves, as if you were doing a thoracotomy or a proper procedure. Please do not think, oh, I'm only putting a small tube, so what? And I can do without asepsis. No, you are entering into the chest of the patient, and if you do it in an unsterile way, you will convert a simple pleural effusion into an empyema, for which the patient will have to pay a heavy price. So please, as you can see in this picture, the person has scrubbed his hands properly. He has put on a proper gown. I would recommend, even if you do it in the ward, we don't always do in the OT. Oftentimes we do it in the ward, but even in the ward, we get a set, a drape set and a gown set from the OT. We ask the residents to scrub properly, put on a sterile gown, mask, cap, put on the gloves in the same way as you do in the OT, and then you proceed with the procedure. It may take 5-10 minutes extra time, but trust me, you're doing a big service, or you are not doing this service to the patient. If you avoid taking these steps, take a shortcut and introduce infection, I think it's not right. Next question, which intercostal space and where in the chest? Well, the exact site will depend on the location of the pathology, but the commonest site is the 5th intercostal space in the mid-axillary line. Earlier, it was believed that air can only be drained through an anteriorly placed chest tube in the 2nd intercostal space. So if there is a hemo-pneumo or a hydropneumothorax, it was recommended that you put one tube in the mid-axillary line and another one in the mid-clavicular line. The current knowledge is that the tube inserted through the 5th intercostal space in the mid-axillary line will be equally effective for draining air also. You don't always have to put a second tube in the mid-clavicular line. Now, you should be careful that a too medially placed tube may injure internal mammary artery. If you go too medially, you can cause that. And in cases of loculated effusion, it's always important, vital, that you do it under ultrasound guide. Now, safe triangle is what we refer to as the preferred site of putting a chest tube, which is an area bordered by the anterior border of lat dorsi, the lateral border of pec major, a line superior to the horizontal level of the nipple, and having apex towards the axilla. It's the usual site. It usually corresponds to the 5th or 6th space in the mid-axillary line. The next issue, what should be the position of the patient? Well, you can put the tube with patient in supine position, patient in sitting position, as you can see in the picture on the right, or even in lateral position. The most preferred is supine position. And as you can see in the picture on the left, the hand is taken towards the back side. So you have the whole chest exposed to you. If you, due to some reason, choose to do it in sitting position, please make the patient comfortable. As you can see, we have put a Mayo stand. There is a pillow over that, over which the patient can sit comfortably and be comfortable. You can't have a patient sitting unsupported and you putting a chest tube. It will be very uncomfortable and unpleasant for the patient. As I said earlier, all aseptic precautions need to be taken, and please look at the area on which the iodine has been put. I would do a pre-cleaning. We will ask the patient to clean up that area. If there's a lot of dirt is there, then we will do first time cleaning, and then we paint with iodine, going to quite wide area, just the way we do in the operative procedure. And as you can see, there is a sterile towel which has been placed behind the patient, and then we drape the area just as we do in surgery, so that all the sides are covered with sterile drape. Now, many times, friends, I have seen just one towel being put on the inferior side, and then superiorly, medially, laterally, everything is exposed. There's no way you can avoid your gloves touching the unsterile area and you end up reaching the asepsis. That's not correct. That's not the right way. Please do get extra drapes, and please see that this area is covered properly. Next step comes local analgesia. It's important that you first choose the site. Okay, this is the site in which I'm putting the chest tube. You raise a skin wheel properly, but before you do that, please warn the patient that I'm going to put an injection. You will have pain, but after this, you will have a painless procedure. Allay the anxiety and then go slowly deeper into the muscles, and you will reach up to the pleura. It's important that you deposit some local anesthesia in the pre-pleural space also, because pleura is the most sensitive space. And this local should be given over a wide area, so that not only at the site of incision, but the area surrounding is also has analgesia. Many times in a very anxious patient, you can complement it by giving intercostal space analgesia, a space above same space and a space below, which will give you analgesia over a wide area. It's important that after giving the local anesthesia, you wait for a few minutes for the effect to occur, because if you make a cut immediately, if once the patient feels pain, then his anxiety level goes up so much that every time you move towards him, it starts jumping even if he's not having pain. Now, it's important that before you give a cut after, and I would do this between the time I've given local and I give the next cut, that you have all your things arranged here. So as you can see, this is a ready-made kind of bottle that we use, but there are all kinds of bottles available, whichever one you choose. So first of all, a chest tube of proper size should be available there. I would always keep a chest tube extra spare by the side. By chance, if this was to fall or something was to happen, you should have a spare available. But more importantly, I will have the bottle opened, whichever one you are using. The saline put in the bottom, as you can see here, saline has been put. The tube has been cut to enough length so that it's ready to be connected. So I would keep the bottle ready to be connected, ready at the bedside, so that as soon as my tube is in, I can connect this bottle. Numerous times the tube is inserted and then you start the process. Acha, sister, please now get the bottle. Then she'll go to get the bottle. This should be avoided. You should be ready with the bottle to be connected without any problem. So next points in inserting the chest tube is, you give an incision, you do muscle and pleural puncture. The entry should be guarded and you should avoid any internal injury, which is an important area I'm coming to. And then you avoid any air aspiration by asking the patient to stop breathing. You hold the chest tube correctly, which direction to go, how much length to put, how to take the suture, how to put dressing. These are important points, and let us look at each of them carefully. Now, a large number of complications have been encountered during this simple chest tube insertion procedure, which include from injury to neurovascular bundle in the intercostal space, to injury to lung parenchyma, injury to thoracic aorta, injury to heart, diaphragm, the needle, the chest tube or the artery forceps going downwards into the peritoneal structures, injury to liver, spleen, stomach, colon. All these are described, and unfortunately, I have myself seen, experienced and managed all these problems. So these can be avoided. Now, injury to neurovascular bundle can be avoided if you remember the anatomy, that the neurovascular bundle runs at the inferior margin of the rib above. So instead of going closer to the inferior margin of the rib above, if you go closer to the superior margin of the rib below, which is towards the inferior side of the intercostal space, now that's the way to avoid injury to neurovascular bundle. Now, as far as lung is concerned, the commonest reason why lung injury occurs is that when you are making the puncture, you don't keep your artery forceps guarded with the other hand. You just puncture. So initially there is the resistance, and as soon as the resistance gives way, just like we have this problem in varus needle insertion also, the artery forceps goes in and it goes and hits into the lung. It can, if it's a long Kelly, sometimes it can injure, especially on the left side, it can injure the heart. There have been reports of aortic injury, esophageal injury, and sometimes it goes towards the diaphragm, punctures the diaphragm and goes into liver or spleen. And especially in trauma cases, if there is a diaphragmatic rupture and your stomach and colon are lying in the chest, you can actually end up doing a gastrostomy or colostomy while putting a chest tube. So one has to be aware and follow some very basic principles, which I am coming to in the next few slides. Another point is to avoid pulmonary edema, and I'll discuss this point in the subsequent slide. So having given the local, before making cut, please check that local anesthesia is adequate and patient is not having pain. Regarding the cut, many people have a tendency of making a long cut and they feel comfortable. Now, if you give a long cut, you will have to put those many stitches, and oftentimes the chest tube is loose. So I would say that your cut should be just a few millimeters more than the size of the chest tube that you are going to put, so that your purse-string suture will be able to adequately cover it, fit snugly around the chest tube. So you give a skin and subcutaneous tissue cut, and then you take an artery forceps and try and open the chest wall muscles till you slowly reach up to the pleura. Now slowly, when you don't try to have a mass puncture in one go, that should always be avoided. Slowly open the muscles in the same direction, keep going deeper and deeper till you reach pleura. When you reach pleura, you will have the same feeling that you would have if you were to take a balloon filled with water and you try and puncture it with the artery forceps. Now that kind of a feeling you get. Once you reach pleura, that's the most crucial step, to puncture the pleura, and that is why the guarded approach is important. As you can see here, the right hand is holding the artery forceps, but the left hand is guarding the artery forceps. So I would fix a distance that, okay, I want the artery forceps to go maybe about 2 centimeters or 1 centimeter, depending on the thickness of the chest wall. I would only allow the artery forceps to go this much. So I put my left hand's index finger at that space, and then I try to push the artery forceps in, so that even if there is a sudden loss of resistance, the artery forceps only goes that much and doesn't go completely into the chest. It's the same principle that we follow in varus needle insertion also, to avoid a complete entry into the abdomen. Once you have gone into the chest, then you just open it at one angle and open it at right angle. So now you will have a proper size. This is like dilatation, just making enough opening. Don't try to make a very big opening, because if you have a very big opening, there is increased chance of peritubal leakage in the post-op period. And while you are doing it, it's important to ask the patient to stop breathing. Otherwise, as soon as you puncture, if the patient is breathing, they will suck in more air. The next step is how to hold, having made the hole, ask the patient to stop breathing, how to hold the tube correctly. Now, as you would see here, the artery forceps or the Kellys which I am using is not protruding beyond the chest tube. It's just stopping few millimeters short of the chest tube. So it will act as a trocar to put the chest tube, but at the same time, in the inside, by chance if lung was to be closed, what will hit the lung is the chest tube and not the artery forceps. So it's important that you hold it in such a way that your artery forceps is few millimeters before the end of the chest tube, and chest tube end is protruding. Now, what direction? it's important because once the tube goes in, it is your artery forceps which will direct which way it will go. You might like to direct it downwards in the posterior recess, you know, the tip of the tube lying in the paravertebral space. That's the commonest position that we aspire for. But sometimes you might like to direct it upwards towards the apex. So that you have to decide beforehand, and accordingly the artery forceps will actually direct. So whichever direction, if you want to direct cranially, your artery forceps and the tube will be directed cranially. But normally you like to direct it towards the paravertebral gutter. So you will go in that direction so that the tube ultimately, when you push it in, it goes in that direction. So direction of the tube is important. Equally important is how much of length of the tube to insert. Many times people go in and then they insert the whole tube and then try to pull it out. No, you have to beforehand decide that, okay, this is my incision. I want to place the chest tube in the posterior recess, ending somewhere near the paravertebral gutter. Okay, this is the width of the chest which my chest tube needs to travel. So I will say, okay, this is so many centimeters, so my chest tube will go this much. Or else maybe I want to go towards the apex. Okay, I want my tip to lie here, somewhere here. Then this is the length that I have. So you please decide which direction you want to go, how much length you want to be in, and accordingly you put that much of tube so that you have excess enough length going in and not too much of length going in. Otherwise later on it will be problem. Once you have put the chest tube, patient cannot hold breath for a long time. So as soon as your tube is in, I think either you yourself or if you have somebody assisting you should take a gauze piece, put the gauze piece around the tube, press it so that there is no possibility of any air aspiration from here, and let the patient take deep breaths before you do a purse string or any other procedure. So this is important because otherwise unnecessarily some air will get sucked in. Of course, the air will come out later, but at the same time you should try avoiding any possible aspiration. And as I said, the tube will be, the bottle, etc. will be ready. So you are ready to connect this as soon as the tube has been inserted. So you can see here, the tube has been put and we have just connected. So the blood or fluid or air, whatever it is, it starts draining. Now, after you have inserted the chest tube, you have inserted in the desired direction, you have inserted the desired length of the chest tube inside the next, and you have given time for the patient to breathe by blocking this with a gauze piece, and patient is now comfortable. The next step is to take a purse string suture. If your skin incision is small, usually one proper purse string suture will suffice. But if you have made a big incision, then maybe apart from purse string, you may have to take 1 or 2 extra sutures also. Now, it's important that your purse string is tight around the tube, and you can check that by trying to move the tube when this suture, the stitch has been taken, the knot has been tied. There should be no movement of the tube here. So skin should be fitting snugly. If there is any movement of the tube here, be sure you will have peritubal leak in the post-insertion period. So once you've done that, then you take the suture around the tube to keep it anchored, and finally you put this knot here. So now you have your chest tube adequately anchored to the skin and not in a position to come out. The next step now is to put a sterile dressing around it. Now remember, this is an area which is sterile, and if you put a dressing like plaster, gynoplast, whatever, directly, those are not sterile things. So therefore, you have to be careful that you put a sterile dressing around it. So earlier, we used to put a gauze piece around it, and over the gauze piece, we used to put the plaster. But many times, this plaster used to come in contact with this area from where the tube is entering. And I thought the inside of the plaster is not sterile. So what I do now is to take a little bit of this cotton. Now this may not be, many people might object, but this is how I do it. I just take some cotton and little tincture benzoin, and first we just put this tincture benzoin soaked cotton around the tube. What it does is it sticks, if you leave it for some time, it sticks to the skin and it forms a very nice snugly fitting layer around the entry point of the tube. The next thing we do, we take a sterile dressing. Now this is a Tegaderm dressing. Any of the sterile dressing usually available for IV site dressing, you can take and you put it around the chest tube at this point. As you can see, we put one this side and one this side. So from here to here, this chest tube entry point is sealed in a sterile manner. Now I'll put a gauze piece around it, cut gauze piece around it, and then I put plaster. Half cut comes from one side, the other half comes from the other side, and you take a flag kind of thing which could be going this way or going across. This will keep the tube anchored to the skin. Whether you use Dynaplast or use micropore or you use plaster, that's your choice. But it's important that you have initial covering of a sterile dressing so that this area is now going to remain sterile as long as this dressing will be in place. It's a small but I think important step. And then we have gauze piece and the plaster. Now another important thing which we have learned along the way is that many times people used to have just this dressing and this tube will be hanging down connected to the bottle. Now many times during shifting etc., there is a pull that causes pain to the patient, and sometimes there could be inadvertent pulling out the tube. So now we've started this what we call secondary strapping, that we give a little loop of chest tube here and then another area where Dynaplast or plaster or something fixes. And another important point, as you would see here, is that the junction of chest tube and the collecting bottle, we put a plaster, because numerous times we've had this issue of slipping of the tube and suddenly the chest tube is lying open. So it's important to secure this junction and then you can secure this chest tube to the side. Now if there is any pull, suppose patient is being shifted, patient is moving, patient is doing exercises, if there is any pull, the pull will be at this point and not at the insertion point, because the insertion point pull causes pain to the patient apart from the possibility of inadvertent pull out. Another small but I think important point. Now as I was saying, it's important to put a proper purse string suture. See what happens if the purse string suture is not done properly. This is image from one of my own patients, chest tube put by one of my team members. The purse string suture was loose, so there was some blood seeping around the chest tube. They informed the sister put more dressing, but the dressing is not the answer. Dressing will not control it. It will only conceal it. The answer is to remove all this dressing, clean it, and then put a proper purse string. So unless you have a proper snugly fitting purse string, your leakage, peritubal leakage can always be a problem. Many times you will have surgical emphysema occurring in patients, particularly patients with pneumothorax. Now, if your tube is draining adequately, I think there is no need to worry. It is normally a self-limiting process. The chest, you have to make sure that the holes of the tube, the commonest cause due to which you get subcutaneous emphysema is that the tube has slipped out and one of the holes of the chest tube is actually lying in the subcutaneous tissue, so air keeps slipping from there. So then the chest tube needs to be removed and a fresh chest tube needs to be put. We usually do not recommend insertion or putting it in of the same chest tube because the outside portion of the chest tube is unsterile. The other reason could be that maybe there is a blockade in the tube or there is too much of air being leaked from inside and one tube is not enough, in which case you should go for a second tube to be put, which could be in the second or third intercostal space, mid-clavicular line. Another, some photos to see that if you don't take the technique properly, here there was some clotting problem with the patient, so you can see a big hematoma. Here the leakage of the fluid around the chest tube has led to a big collection around the breast, and this patient, the chest tube dressing was put and not changed for about a month, and you can see what kind of excoriation. Just a small points that you have to check the clotting part carefully. You have to be very careful with snugly fitting purse string around the tube, and of course the dressing, etc. have to be taken care. The next important step is how to connect, what kind of water seal. So when I was resident at that time, we used to have this bottle, the saline bottle, in which two tubes, glass tubes were put. One was going underwater and other one was in the air chamber. Nowadays, I think most of the places we have these ready-made bottles available, which could be single chamber or double chamber. And of course, some places bags are also used. Now, bags are okay. The only problem with bags is in case you need to apply suction, there's no way you can apply suction on the bag. And many times there is the problem of slippage of the bag and the bag becomes flat, and then your underwater part goes away. So I would personally recommend using one of these ready-made bottles. It's important that you prepare the bottle properly. All these bottles have very, very long kind of connecting tube. And if you leave a very long loop of tube, especially lying on the floor, it actually forms a pressure head against which the air or fluid has to come out. So I always check the distance that, okay, if I'm keeping on the floor and here is the patient lying on the bed, this is the length required. Leave 6 to 8 inches extra for movement of the patient, and your tube should be coming straight. Now, whatever fluid or air comes in this tube will go straight into the bottle. If you have this kind of a loop or a long loop or multiple loops, there will be more resistance to the flow of air or water, and it will not come out properly. Now, after you have inserted the chest tube and you settled all the things, the first thing you should do is to auscultate the patient's chest. You have auscultated before insertion, you should auscultate immediately after insertion, and you would find that the air entry now definitely should be better because the air or fluid would have been drained. It's always important to do a chest x-ray sometime as soon as the patient is stable, to be able to document that yes, whatever reason I put it for, whether it was fluid or blood or air, it has now drained. Now, how much to drain? If there is too much of fluid inside and lung has been collapsed for some time, if you put a tube and you drain the entire fluid completely and the lung expands suddenly, sometimes patients can go into pulmonary edema, what is known as re-expansion pulmonary edema. So it's always important to let the lung expand slowly. So if you have a massive effusion and lung has been collapsed for a long time, it's important that you initially drain about a liter, then clamp it for a few hours, drain another 500, 600, 800 cc after 4 to 6 hours, clamp it again, clamp it, and do it in aliquots of about 5, 6 to 700 cc's at a time. And slowly, also keeping a watch on the hemodynamics of the patient, because sometimes sudden drainage of a large amount of fluid, especially in a hypovolemic patient, can actually lead to hypotension also. Another very vital piece which is often neglected is pain relief. You put chest tube for some chest condition. For the lungs to get well, it's vital that the patient takes a deep breath. And patient will only take a deep breath if taking deep breath is not causing him pain. If taking a deep breath is causing him pain, patient will not take deep breath. And that will only come if you give pain relief. Many times we feel, oh, it's a small procedure, I have given 1 tablet of crocin, that should be enough. Please be liberal with painkillers. It's important to give liberal doses of oral or parenteral painkiller, have the patient pain free, and make him do breathing exercises, because your aim is to have your lung expanded, and lung will only expand if the patient takes a deep breath and does exercise. Now, I have found bedside sit-ups to be a very good, although a very crude, but very good exercise. I just ask the patient to come. Of course, you have to ensure that he's hemodynamically stable and not suffering from any knee or spine problem. But having ensured that, I just sit down myself by the side of the by the bedside and say, okay, do like this. Please sit down, get up, sit down, get up. Few times you have patient breathless. So you can start with a small number and slowly improve, or we have a treadmill also in our unit. So making him walk on the floor, making him go up and down the stairs, making him do sit-ups, or send to your physiotherapy, whichever method you use. But it's important to have the patient moving about. It's not right to have the patient in the bed, because a bedridden patient will retain secretions and the lung will not expand completely. Trust me, for proper lung expansion, pain relief, patient movement and breathing exercises are vital. And whether you want to use painkillers orally or you want to use something more, that's your choice. And let me tell you that there is many times we have this notion, chest tube should only require crocin twice a day, nothing more than that. Why should he need more than? Well, friends, everybody has a different pain threshold. End point is not how much painkiller you have given. End point is patient should be pain relief. Person A may be pain relief with 1 tablet of crocin for 24 hours. Well, good. Person B may need an injectable dose given twice to achieve the same level of pain relief after the same procedure. So please don't be rigid about how much to give. Please pay attention to the end point. And the end point is a completely pain relief patient. Now, the bottom part of the slide is about epidural catheter. Now, a chest tube insertion obviously does not need an epidural catheter. Oral or intramuscular painkillers will be more than enough. But I have shown this epidural slide especially because many of the colleagues will be dealing with chest trauma patients, and many of these patients have multiple rib fractures. Now, most painful condition in the body is when you have multiple rib fractures. You're breathing 20-25 times every minute, and every time you breathe, the rib ends move, they clash with each other, and the patient has excruciating pain. So what they do, they make the chest tight, there is no movement on that side, they just refuse to cough, so they retain their secretion, there's no air going to that side, and ultimately 3-4 days later, these patients end up with a complete collapse of lung on the side of trauma or on both sides, and then they go on ventilator. This is something we are seeing very often, and that's where in the last 20 years, epidural catheter has made a huge difference. So if you have a patient who's got multiple rib fractures, particularly if it's bilateral, please do request your anesthesia colleagues to put an epidural catheter. You can give twice a day injections, or if you have facility as we have, you can see on the bottom right picture, this is a pain pump which actually keeps giving continuous dose of analgesics to the epidural, giving a 24/7. There is a button which patient can press. So we can give a continuous dose, and there is a top-up facility also. So I'm not at all suggesting epidural for any chest tube insertion. Chest tube insertion pain is to be managed with oral or parenteral analgesics. But if you have a chest trauma patient who's got multiple rib fractures and you are managing, you put a chest tube. Now this is a situation where adequate pain relief with the help of epidural will not only allow the patient to breathe well, but you will also be able to make him do physiotherapy, which will bring out all the secretions and let him have a completely expanded lung. Time and again we see when the patient presents, they have a proper expanded lung, and 4th day the lung collapses because of retention of secretions. Afterwards, milking of chest tube. So if there is a lot of blood or something collecting, you have to keep emptying that. Now, sometimes when we don't recommend suction devices routinely, I would only recommend that you connect the chest tube to a underwater drainage bottle and have the fluid draining. But sometimes if the lung does not expand, there could be in specific situations role for a negative suction device. There are various types of devices available. There are these digital portable devices from Medla company which we are using routinely, or there are various other suction devices available which can be connected to the wall suction, and you can have variable amounts of suction applied. But I'm not recommending routine use of suction devices. These are to be used in specific situations. Now, a very important practical point is daily emptying of the bottle. Now, this is a point which is usually left either to nurses, who some of whom may not be aware, or many times I'll share my experience at my previous place, where nurses actually used to leave it to the sweeper in the ward. So what he used to do, he used to open the bottle and just hang the inside part, or make the relatives hold it and go and empty it. Now please, this is a sterile system, and this system needs to be emptied in a sterile way. So when you open the bottle, when you are emptying the bottle, when you are putting the inside part back into the bottle, or when you are putting saline into the bottle, at all these steps, friends, sterility has to be maintained. So now in my unit, it's a clear-cut instruction that these are only done by nurses under supervision of one of the residents. They don't do it ever alone. If they have to empty, they will call one of the doctors and they do in front. It's a small step, but trust me, a lot of time asepsis is broken in this step, and then you can have ascending infection going into the chest. Now, many times these patients will be shifted for X-ray or for other reasons, and while shifting the patient, it's not uncommon to see the chest tube getting pulled out. I have faced this problem. I'm sure many of you would have faced. So this secondary strapping helps prevent that. And the other thing is, the resident or sister, whoever is shifting, have to be careful that the clothes should be removed. The tube, the collecting system should be visible before you shift the patient. As I said, I stress a lot on mobility of the patient. So a mobile patient will have much less chest complications. So whether it is the portable suction device or it is the pain pump which is hanging, it's important to have patient mobile doing exercises. Some of these patients will be suffering from chronic illness sometimes, and they may not be able to eat adequately because of various reasons. Similarly, if you have a polytrauma patient and the patient has abdominal injury, he may not be able to eat. So if few days have passed by, it's important that for long-term recovery, you take care of the nutrition also, and we utilize rice tube feeding quite regularly. So within a day or two, if patient is not able to go back to normal oral feeds, we put a rice tube and give them about 2000 to 2500 calorie high protein liquid diet made in the hospital through the rice tube, and this can be continued even when the patient. So please pay attention to nutrition and to mobility of the patient. Now, after you have put chest tube, you have to auscultate and see that there is improved air entry. You do a chest x-ray and you see that the lung is expanded. But sometimes you do a chest x-ray and you find that the lung is not expanded. Now, this cannot be left like that. You put a chest tube, lung does not expand, it needs further workup. Now, what are the possibilities? Maybe your chest tube is blocked. So then you please check the chest tube. You ask the patient to take a deep breath and see whether there is movement of the column with respiratory movement. Ask the patient to cough and see if the underwater seal, the level of water in the seal is moving. That will tell you whether the chest tube is patent or not. Suppose you have ensured that the chest tube is patent, that the lung is still not expanding, then that means there is some kind of a blockade to air coming to the lung. Now that could be, a commonest cause is retained secretions in the main bronchus forming a mucus plug, or who knows, there might be a tumor lying there, or who knows, there may be lung has been collapsed for quite some time and a peel has formed around the lung which has not allowed this lung to expand. So you will need to do a CT or you will need to do a bronchoscopy to see. By bronchoscopy, if there is a mucus plug, you will be able to suck out the mucus plug. This problem we see often in trauma patients, that despite chest tube, lung doesn't expand, you go in and do bronchoscopy. There was a big mucus plug, you suck out the mucus plug and immediately the lung expands. So long and short of the story is that if you have put the chest tube and the chest tube is patent, and within 12 to 24 hours of insertion of a chest tube, if lung does not expand, you cannot just wait and hope that it will do so on its own. You need to do something more, and bronchoscopy or CT is the next step to find out what is the cause of that. Now, you have put the chest tube, you've maintained it adequately, you've taken care of all the drainage and everything. lung is fully expanded, patient is recovered. Now a time has come to remove the chest tube. When do you remove the chest tube? What are the prerequisites? Well, first of all, the lung should be fully expanded. You cannot remove a chest tube if the lung is not yet fully expanded. So clinically, you will auscultate and you will do a chest X-ray and ensure that the lung is fully expanded. There should be no air leak for more than 24 hours. Obviously, if there is air leak present and you remove the chest tube, the lung will collapse again. Now, why this 24 hours period? Numerous times we've noticed that you ask the patient to cough and there is no air leak, but few hours later you ask the patient to cough, there might be a bubble or two coming out. So that's why we give this 24 hours time, that if there is any leaking point, we just want to give enough time, because the last thing you want to do is to go back and need to reinsert the tube. There should be no fresh blood coming from the chest tube. There should be no altered blood coming. If you have dark altered blood coming, that means something is still there, or you have pus coming, then you can't remove the chest tube. Drainage is variable. It will also depend on the body size. If you have a short statured patient, 100 cc, and if you have a tall patient, maybe up to 200 cc. So anything between 100 to 200 cc's per day, I would remove the chest tube. But the prerequisites are, number one, the lung should be fully expanded as seen clinically and confirmed on chest X-ray. There should be no air leak. There should be no fresh blood, no altered blood, no pus, and the drainage is around 100 cc or so. Now, patient position, while you remove the chest tube, again, you have to do it in the supine position. Again, as in insertion, it's important to explain to the patient what you are going to do and rehearse it several times. So what I do is I open the stitch and I just move the tube little bit there so that they would know what kind of pain they are going to experience. If your chest tube has been there for a long time, many times the skin around that becomes excoriated, and your purse string, if you try to tie, does not hold, does not close the hole. In that case, it is better to take a gauze piece and just pull out the tube and cover that area with a gauze piece and put an occlusive dressing, because if you try and tighten that purse string, it will cut through. But if it's been there only for about 5-7 days, it will be possible. So you pull out the tube and side by side, you tighten the purse string so that the air does not go inside. But important thing again is to explain to the patient, and if you can manage to give some local to the patient, trust me, you will have a lot of cooperation from the patient. Again, after removal of the chest tube, so before you remove the chest tube, you auscultate. After you have removed the chest tube, you again auscultate that there is no decrease in the air entry. You do a chest X-ray. After patient goes home, it's important to tell them to continue to do the breathing exercises. The pain relief part has to continue. You have to talk to them about what movement. There is a general belief, oh, he has had a tube inserted, he must go and lie down on the bed. So numerous times we have seen patients going home and not moving at all. So you have to give these instructions that, okay, now you are allowed normal movement. You have to tell them when they have to come for dressing removal, when they have to come for stitch removal, and of course, if there is any underlying disease, the definitive treatment has to be given. Sometimes after removal of the chest tube, you have patient has taken a breath and some air has gone inside. What do? You do a chest X-ray, you auscultate, you find there's a slight decrease in the air entry, do a chest X-ray, you find the X-ray has shown some pneumothorax. What do you do? Well, first of all, you have to see whether the patient is comfortable or patient is in distress. If the patient is comfortable, and your chest X-ray reveals the pneumothorax to be occupying less than 1/3 of the horizontal size of the chest, then you can probably observe. Don't discharge the patient, don't send him home, because if he goes home and this increases, he will have to rush to casualty in an emergency situation. Keep him in the hospital, observe, auscultate frequently, maybe repeat a chest X-ray the next day. And if the patient continues to be well and an X-ray shows reduction in the amount of pneumothorax, you can then send the patient home. But remember, any patient who becomes symptomatic, who's dyspneic after chest tube removal because of pneumothorax, or you do serial chest X-rays and you show that the pneumothorax is increasing. So it was 1/3, next day more than half of lung is correct. This patient definitely needs a reinsertion of the chest tube. A few words about loculated pleural effusion. if you have loculated pleural effusion as a particular area. In olden times, we used to do a PA and lateral chest X-ray, localize it, and then try and put a chest tube. That's not done anymore. Ultrasound is freely available. In fact, a lot of surgical units across the country now have access to ultrasound. Otherwise, you seek help from your radiology colleague. And all loculated pleural effusion should be drained under ultrasound guidance. Now, it could be done there. You want to do it, you take the patient to a radiology suite, ask them to do an ultrasound, tell them to give the best accessible window, try and inject, aspirate there with a needle or Venflon, and mark the site. Okay, this is the site. You can bring the patient back to your ward or OT and put the chest tube there. Or nowadays, most of the radiology suites are equipped to put this. But trust me, the asepsis in the radiology suite may not be as much as you would like to have. So given a choice, bring the patient back and then put the chest tube, or else ensure that the asepsis is adhered to in the radiology suite, and they can put, whether they put a pigtail catheter or a bigger size chest tube will depend on what it is. If it's just fluid or air, a pigtail will suffice. But if it's a pus which has some ecogenic material inside, it's better to put a 24 size chest tube, which your radiologist colleagues will be able to put. One very important point, when not to clamp the chest tube. Many times I have seen when the patients are being transferred from one bed to another, from ward to radiology suite, or various other places, there is a tendency, the first thing the sisters will do is to put an artery clamp on the chest tube. Well, friends, when patients are on positive pressure ventilation or continuous positive airway pressure, which means CPAP, or they are having an air leak, so whether at the time of changing bottles or tubing, whether during nursing procedures, whether for physiotherapy or during transportation, please do not clamp the chest tube. If the patient is having an air leak and you clamp the chest tube, you are inviting tension pneumothorax, especially if the patient is on ventilator. So any patient with air leak present, no clamping of chest tube except for briefest possible period if you're trying to empty the bottle or some such thing is being done. But otherwise, do not clamp the chest tube. Unfortunately, very simple, very basic step, but often neglected, and I have seen tension pneumothorax developing because of this. Now, during transportation, I see no reason why tube should be clamped. Most of the trolleys these days have a jali or something under the bed, and the bottle can always be kept, or they have a hook by which it could be hung by the side of the trolley. So continuous drainage is the safest approach. Of course, when changing the ICD bottles, clamp the tube for shortest possible period. Another very important point, the last two lines, ensure that the drainage bottles are kept at a lower level than the chest. Because many times I have seen the patients will pick up the bottle and they take it at a level higher than the point from which the chest tube is entering, and the fluid can actually go back. So please explain to them that this bottle at all times is to be kept down. Now, complications, as I said, from hematoma at the insertion site, injury to neurovascular bundle, injury to lung, injury to heart, aorta, esophagus, diaphragm, liver, spleen, colon, stomach, all these have been described, from simple to life-threatening. But friends, I feel if you adhere to the basic principle that, okay, this is the site where it should be inserted, these are the basic steps. The most important is when you are putting the artery forceps inside. If you have your other hand guarding the entry of the artery forceps, I think a lot of these problems can be avoided. So I would conclude by just reiterating some of the important points. It's very important to take consent from the patient. It's very important to explain to the patient what you are going to do. It's vital that you pay attention to asepsis. Please remember, you are entering the patient's chest and you have as much chance of giving him empyema if you don't adhere to asepsis as you have if you were to do a thoracotomy. Please have a checklist and ensure that all items are available at the bedside or in the ward before you make a cut. Proper position is important. The person who does this should have experience, or if somebody new is starting, he should have an experienced person assisting him. Proper fixation of the tube is important, otherwise you will have fluid leaking around the tube, which will be unpleasant for the patient and unpleasant for you. Now, how much to drain at a time is important, and in massive effusions, please do not drain the entire amount, otherwise sudden lung re-expansion will lead to re-expansion pulmonary edema. It's vital that you auscultate before insertion and auscultate after insertion, and do a chest x-ray after insertion and document complete expansion of the lung. If the lung is not expanded within 12 to 24 or up to maybe 36 to 48 hours after insertion of the chest tube, please check whether the chest tube is patent or not. And if it is patent, you need to see why air is not coming to the lung. It could be mucus plug or something else, and it needs to be taken care of. So bronchoscopy or CT is the answer. Now, maintenance of the tube, daily emptying is an important step which should not be left to the sweepers. It has to be done in a sterile manner. Pain relief is of vital importance. If you don't pain relieve the patient, he will not breathe and he will have many complications, particularly chest infection. In long-term patient, nutrition is important. If the patient is not able to take orally, please do not hesitate to put a rice tube. A lot of patients have been saved by putting rice tube and force feeding them, and later on, as their general condition improves, their appetite improves. Now, when, where, and how to remove the chest tube, we have discussed it. Please follow these principles, but always look out for post-removal pneumothorax and act. If the patient is comfortable, wait, otherwise reinsert the chest tube. Pain relief is important, exercise is important, nutrition is important, but of course, chest tube insertion is just one part of management. If the patient has some other problem, definitive treatment for that problem is also equally important. Friends, I would conclude my presentation by saying that it's actually every patient's right, I would say, to have the chest tube inserted, which is a basic procedure like tracheostomy. Chest tube inserted in a safe manner, maintained in a safe manner, and removed in the safe manner, just as we do for other things. And I think it's a duty of every doctor, not just chest physician or a pediatrician or surgeon. It's a duty of every doctor to be able to put a chest tube safely. So let us all join hands and achieve safe insertion of chest tube. Now, this talk which I have given is also available on the YouTube, and I have put the link here. This can be seen. Anybody who was missed out can actually see it at the YouTube also. Thank you very much, friends from across the country, surgeons, pediatricians, physicians, chest physicians, and any other specialist who has joined. On behalf of Association of Surgeons of India, on behalf of Healthium, I thank you from the bottom of my heart for sparing your valuable time and being part of this discussion. I would also thank Professor Malik for sitting through the presentation. And of course, now I will be quiet and Dr. Malik will be taking charge. We'll be happy to take questions from everyone. As Dr. Malik has told you, there are various ways. You can put it on the chat window. You can WhatsApp to us. You can get in touch with your Healthium representatives. They will send the questions to us and we will be very happy to answer. Thank you very much.
So, small statistics. As we speak, there are more than 470 logics. Our estimate is that there are 3,000 surgeons watching this.
Well, I'm informed that there are more than 3,000 doctors, I would not say all surgeons, chest physicians, pediatricians across the country who are watching. Well, friends, thank you very much. It's a very important topic and we really appreciate and value your participation. And we equally will value your feedbacks, your criticism, your suggestions. Thank you.
Thank you, Professor Arvind Kumar, for a very power-packed, comprehensive, and in-depth coverage of the subject. You have given very clear guidelines about how to do the procedure, how to get the best results out of it, what complications are possible, and how to avoid them. I think these guidelines should help us in achieving the most optimum outcome for the patients who present to us with an indication of a chest tube drainage. There are, of course, certain questions and certain clarifications that the audience has sought. I may not be able to name each one of them, and I'll moderate these questions according to a manner that the gist of it goes to you, and without naming the persons, because I think some of the questions are quite overlapping. And also to the audience, I would like to mention that some of the questions were generated during the time when Professor Kumar was in the early part of his presentation, so they were covered up in the later part of his presentation. So necessarily those questions will not be addressed again. One question that has come up is that would you always aim at fifth intercostal space, or would you change, other than of course the situation of a encysted or loculated collection, would it be always a fifth space, or you would change it depending upon the habitus of the patient, the sex of the patient? That's one question. People have, quite a few of them have addressed these questions too.
Yeah, so if I look at all the chest tube insertions, the commonest indication with us has been pleural effusion, and most of the times it's a generalized pleural effusion. And if you want to drain this fluid, fifth space mid-axillary line provides you the best portal. Of course, the fifth could be sixth or higher, depending on the position of the diaphragm. Sometimes if the diaphragm is very high placed, I might shift this fifth to the fourth space, but you don't want to go too high, because if the diaphragm is normally located and you put in the fourth space, then you have a couple of spaces which are below the chest tube, and we have seen many times some amount of fluid remains in the posterior recess. So it's important that you enter and you try and have your chest tube. Ideally placed chest tube will be one which goes into the posterior recess and the tip lies just at the paravertebral gutter. If it's in the posterior recess, imagine if the patient is in sitting position, the entire fluid will drain down, go into that space and get drained from the chest tube. So it will give you the best possible egress for the fluid. Of course, if it's only air that you are putting it for, you could theoretically put it in the third space in the mid-clavicular line. But my experience has been that many a times these patients have some fluid also accumulating at that time or later. So if you put a tube in the fifth space, it will not only drain the air, but that fluid which may come into future. But if you put it in the only mid-clavicular line, and then you later on you have fluid accumulating down below, that fluid will not get drained. So I guess fifth space gives you the best.
Fifth space and the mid-axillary line, or would you like to be closer to the anterior fold of the axilla?
It is mid-axillary or a little bit on this side, that side. That of course I will modify according to the body habitus of the patient. Also remember, you should imagine the patient in lying down position and never have chest tube coming out of the area that will be touching on the bed when the patient lies down. So sometimes I have seen chest tube being put on the back side, and when the patient lies down, the tube actually gets kinked because the patient is sleeping on the chest tube.
It's so very, very important.
That should not
be more towards the anterior fold.
It should be in such a way that patient, when he's lying down, the chest tube is draining without any kinks and cuts.
I think it clearly states what should be done in this situation.
Sure. Okay.
We'll do that. We've been told that there are too many questions, so we'll sort of combine a few questions and keep the answer a little shorter because everything has been covered up very nicely.
I'll keep the answer short.
Another point is that directing the chest tube towards the posteriorly in the gutter or upward towards the apex. how do you really guide it? And is it really very important to guide it, or it is something which is not of that importance, that if you just guide it towards the gutter, it will take care of the connection as well as the air?
So I would guide it, as I said in previous answer also, that my ideal position is a tube lying in the posterior recess, with the tip being in the paravertebral area. Okay. If you can get your tube there, it would drain fluid as well as air completely. So I would, guiding is important, because if you just insert, say this is the body of the patient and this is the hole. If I insert like this, and then when I put the tube, it will have a tendency to go towards the apex. So initial, when I'm holding the tube, initial entry should be in that direction. Initial entry should be in that direction, like that, and then you put the chest tube so that the chest tube goes in that direction. Try and visualize the tube lying in the posterior diaphragmatic recess. If you get your tube in the posterior diaphragmatic recess, it will function in the best possible way. So
if the tube is larger, you have mentioned, that you should visualize, one should visualize, how long the tube you want inside. If you find the tube is larger, and we know that the last hole is, would be out in case, we just have that amount of tube inside. So is it safe to cut the tip of the tube?
If your tube length, a patient is very short, the width is very less, and you feel that the hole, by the way, the way the holes are made, they are made only in the beginning part. So rarely will this possibility be there that your hole will be lying outside. Usually we have to make extra holes, because you want the last hole to be about an inch or so inside the parietal pleura. You don't want it too close to the chest wall. You want it about an inch inside the chest wall. And when you make extra holes, please make hole along the radio opaque line, so that your chest X-ray, you will be able to see where is your last hole. So, but there certainly, if you feel your hole is going to lie too close to your chest wall, you can always cut the tube. And if you think too much tube is there inside and you need to make extra holes, please do make extra holes.
One related point on the technique of insertion. Some people have mentioned about after you enter the pleura, putting in the finger and making sure that one has gotten to the pleural space, and also taking down some of the adhesions that may be present between the lung and the chest wall. Do you think that this part of the maneuver, is it a good maneuver, or it should not be done, or will it make your incision larger and would be counterproductive?
Excellent question. So the answer is, if you are putting for, say, a massive pleural effusion and the lung is collapsed, you know that the lung has already moved away from the chest wall and there is no need to put a finger or something there. But certainly if you have some, chest X-ray is showing that the lung is still reaching up to the chest wall and you feel that lung could be adherent there, then there is no harm in putting the finger and doing some maneuver. Two things I have against this putting finger. One is, it will necessarily need a hole bigger than the chest tube. That's one. And two, I have found this to be extremely painful. No matter how much of local you give, when you put finger and you do this maneuver, it causes more pain. When you have pneumothorax and lung collapse, when you have hydro or hemothorax and the lung collapse, then the lung is actually away from your chest wall. So the possibility of your tube injuring the lung is remote.
Okay. Another point, when you mentioned about removal, would you like to have a pre-placed U-stitch already placed at the time of insertion of the tube, or would you like to take it afresh when you are pulling it out? So some people put in a prefixed stitch.
Yeah. So our practice is that the purse string that we take at the time of insertion, we just tie one knot and then we wrap the two ends around the tube and just leave it there under the plaster. So at the time of removal, we just untwist the two loose ends and our one knot is already there. So some other person, so first you explain to the patient that you have to take a deep breath in and hold, and then you pull out the chest tube. What I do is to do a maneuver of moving the chest tube and see that the patient does not start breathing. Many times the moment they have pain, they'll start breathing. So you have to tell them that please don't breathe, otherwise there'll be problems. So you tighten the tube and the stitch as the chest tube is being pulled out. Now this is possible if your stitch has been there for a week or so. But if your stitch has been there for a long time, there is usually maceration of skin around that area, and then this stitch doesn't hold. Then I take a gauze piece, make a fold of it, and just block that with a gauze piece. Put more gauze pieces over that and put a tight plaster to occlude that opening.
And once you have done that, when would you finally take off the dressing?
So we remove this occlusive dressing after 72 hours, by which time this hole actually would have closed. So if you have put a purse string, then we change the dress. If we have put a purse string and the purse string is very nicely closed, then you need not put an occlusive dressing. We just put a telederm or a small gauze piece and ask the patient to remove it after 48-72 hours, and then this can be left open and we remove the stitch on the 8th or 10th day. But if I have not put been able to tie the purse string and I put occlusive dressing there, we remove it on the 4th day. By 4th day, usually that hole would have got closed and we remove it. But if we have any doubt, after 4th day removal, changing, you put another occlusive dressing for another 48 hours, by which time the hole normally closes on its own, and then there is no possibility of air being sucked in.
Very nicely explained. Question, which is there are two related questions. One is that if you need to reinsert the tube, what will be your site? I mean, you have taken out the tube, and then a day or two later, you find that you have to reinsert the tube. Yeah. Where would you like to put
so you do not go from the same hole ever again. If you remove the chest tube and you find that there is post-removal pneumothorax, you decide to observe. 48 hours later, you do a chest X-ray and find that the pneumothorax has increased, or the patient is now tending to become a little bit breathless and it's time for you to reinsert. You would reinsert from a site one space above or below, little anterior or posterior, but not from the same site. Because then you increase the chances of infection. There is increased chance of peritubal leakage because this wound will already be macerated.
You have nicely mentioned about how to fix the tube, and I think this is very crucial. But we have seen instances when the tube has slipped out within a day of its insertion because it was not properly fixed. In that situation, what would be your advice?
Yeah, so the advice would be, suppose patient is being shifted somewhere and somehow the tube gets inadvertently pulled out. The resident or the nurse, whoever is there, their first response, the reflex should be to take a sterile gauze piece of cotton and just block that hole and put an occlusive dressing. That's number one. If the patient is having air leak, then it's an emergency that you put the tube as quickly as possible. But if the patient was not having air leak, then you could take time. At the most, fluid will collect. And then you would take the patient back to ward or theater, be comfortable, and put a chest tube again from a fresh site, unless it was just maybe 24, 48 hours and this wound is still fresh, then I may possibly use the same wound. But otherwise, if it's many days old, I would go for a new wound. The reason I've seen is that in the beginning, when we moved here, many patients used to come with chest tube, and after surgery, we put chest tubes in the same hole, but a lot of infection and excoriation and stitch getting loose, those kind of problems were occurring. So we decided that when we reinsert, we would go from a fresh opening.
One of the complications which can be very unnerving to a young doctor is bleeding from intercostal vessel.
Yeah.
So if that were to happen, what would be your advice to such a doctor and how to manage it?
Yeah, so best is to avoid these complications by just paying attention to basic steps. So if you palpate the ribs and the intercostal space and site your cut and your entry puncture at the upper margin of the lower rib rather than at the lower margin of the upper rib, which is where the neurovascular bundle is running, I think you would avoid inadvertent injury to this. But should that happen, the patient may bleed outside or may bleed inside. If the patient is bleeding outside, well, then you have no choice but you have to shift the patient to theatre, have proper exposure in the theatre. Usually, it may not be possible to do it under local, some kind of anesthesia support, not saying intubation, but some kind of anesthesia support is needed. You have to have proper light, you have to have proper asepsis, you have to have all your instruments available, and then you enlarge the incision a little bit, see the bleeding side, and underrun it. Now, if it's going inside, then it would be coming out through your chest tube, and you will have more than 150 to 200 cc per hour of blood coming in the chest tube. Then that becomes an indication for exploration.
How frequent is exploration for such inadvertent bleedings? In your long career, have you encountered such situations?
Bleedings, I would only encounter if they occur in my setup. If they were to occur in another setup, they won't reach me. Bleeding would be something which will need to be necessarily controlled locally. So therefore, in my setup, since it's a very controlled environment, it's not common. But yes, I do remember there have been instances where we have had to take the patients to theatre. And as I said, if it's coming outside, you have to just enlarge the incision a little bit and find out the source and suture. Only thing I would say, blind putting stitches may not help. You need to enlarge the incision, proper exposure, proper light. Ask for some help. If you've done it, and there's some bleeding, you may be under pressure. So it's nice to have your senior or somebody walk in and assist you. And if it's going inside, then of course it's coming out in the chest tube. You won't be able to know whether it's actually intercostal bleed or it's lung bleed or which bleed. Then patient will probably merit an exploration.
Tube blocks. I think it's time that you should take a gulp of water. I think we've been keeping you busy.
No, it's fine. I'm okay.
So tube blocks, anytime around we put in tubes in surgery, we know that they can get blocked. So once that kind of situation happens in an intercostal drainage, in which you mentioned would be known when the air column stops moving. So you have also mentioned, what should be the post-operative regimen in this patient to avoid that complication. But if it were to occur, what would be the options for that?
So here also, prevention of tube blockage is the best option. So why does the tube get blocked? The tube gets blocked because there may be blood, and usually it gets blocked when it actually gets kinked. So the column is there and the blood clots inside. If the blood is there and the blood is draining freely, it will not get blocked. But sometimes there could be kinking and the blood column remains inside and that gets blocked. Now, if you have a blocked chest tube, the first thing I want to tell everyone is there is no role of flushing of the chest tube. Please, friends, be very clear. Sometimes I have seen people taking a 20 cc syringe, filling it with saline and pushing the saline. I've seen people taking an asepto syringe and connecting it and flushing. You will introduce infection from outside. Sometimes there will be clots in the tube. You could try to milk the tube, hit the tube with your finger, try to break those clots. I have seen a continuous kind of a long clot coming out of the tube. So you disconnect from the tube and the connecting tube junction. You block the tube here, take an artery forceps, hold that clot and just rotate it gently. Sometimes it comes out like a long snake. It comes out and your tube opens up. But if it doesn't, you have to remove this tube and put a fresh one. Please do not flush a chest tube. There is no role of flushing because you will 100% introduce infection from outside into the chest cavity and you may not even end up opening the chest.
Right. Yeah. So, very important message that you have given there. And is there any role of applying intermittent suction? In which situations after chest tube placement you would recommend?
Question. Yeah. So as a matter of routine, there is no need for putting suction in every patient. Whether patient has pneumothorax or patient has pleural effusion or hemopneumothorax, you put a chest tube. Ensure that the bottle is put properly. Ensure that there is no kinking of the chest tube. Sometimes your stitch may be tight and there could be some narrowing here. Sometimes when you take this loop and you do the dressing, the angulation may be such that there is some kind of an obstruction occurring. This prevents complete egress of fluid and air and leads to persistence of pneumothorax or hemothorax. But if you have egress completely, ask the patient to cough. Physiotherapy is vital. You know, when the patient takes a deep breath and is able to breathe nicely, the lung expands and lung pushes the air and fluid out of the cavity. For me, the single most important factor that I want to see in the chest X-ray after insertion is lung expansion. If the lung is expanded, friends, all air leaks will stop. If you get complete lung expansion, and there are some minor air leaks, those are usually from the parenchyma, periphery, 100% of peripheral air leaks will stop if the lung is expanded, because the lung goes and sticks to the chest wall and it forms a buttress there and it stops there. So there is no suction. But if too much of air is being produced, your 1 tube or 2 tube may not suffice. In this cases, we put sometimes suction. So whether you have, so if despite drainage, the lung expansion is not complete, especially if you have a lot of air leaking pneumothorax, to suck that out, we then put chest tube. Also, in empyema cases, after surgery, we use suctions routinely because many of these cases have lung collapse for a long time. And even if you decorticate, it takes some time for the lung to expand. So we like to maintain a negative suction in the chest. In those cases, we do use either a digital suction or a wall suction connected to your underwater seal. But routine use of suction is not.
That's great. One particular query is regarding emphysema around the at the insertion site.
Yes, yes.
And if it is increasing in amount, is it worrisome and how to handle it?
Excellent question. It's a very, very worrisome thing, not for the doctors, but for the relatives. Sometimes this comes locally, sometimes it expands and air being light goes to the anti-gravity. So if the patient is sitting up, the air will come to the neck, the voice starts getting affected, air can come to the face, the eyes will close and patient starts looking grotesque. The relatives are absolutely in panic situation that something is going wrong. And the voice getting affected is the last thing. So the first thing is to check the position of the chest tube. The commonest cause is a hole lying in the subcutaneous tissue. So please look at the chest X-ray carefully and see whether the hole is lying in the subcutaneous. If so, that hole needs to be inside. Well, you may, ideally, I would put another chest tube. But if not possible, then you may actually like to just clean up the area outside. As I said, ideally, I would reinsert the chest tube. I don't recommend insertion, but then in this situation, it may not be possible. So remove the dressing, clean the area around the insertion site with betadine, etc., and then insert so that this now lies inside. Ideally, I say the re-chest tube. Or else, if there is a lot of air leak from the lung, especially in emphysematous lung, and the air leaking is more than what your tube can drain, then the tube air starts tracking around the tube site. In that case, you put another tube in the second space or third space, and then we connect both the tubes through a Y cannula to a suction device so that you are able to suck out more than what is being leaked from the lungs, and then the emphysema stops. Now, there is a role for giving subcutaneous cuts, and the ideal place for giving the subcutaneous cuts is in the infraclavicular area on both the sides. I would not need to do it more than once in 2-3 years, because most of the times with the adequate drainage, suction, another chest tube, tube position being checked, stitches being tightened, all these measures will ensure that your subcutaneous emphysema starts decreasing. But if you have it making the patient uncomfortable, patient has difficulty breathing, face is looking grotesque, then the ideal place is to give cuts in the about 3-4 centimeter long cut in the infraclavicular area, one side or both sides if it's bilateral, and then take a pad and roll the subcutaneous tissue towards that area so the air actually gets drained from there. Another thing to tell the relatives is that once the air has leaked into the a subcutaneous space. 20% is oxygen, which gets absorbed immediately. 79% is nitrogen, which takes a long time to get absorbed. And you have to tell them that this may take up to 4 to 6 weeks to resolve completely.
Regarding removal or after the lung has expanded, and you mentioned that if the lung has expanded, even if the fluid in the chest tube is in the range of 100 and 200 cc, and it is clear fluid, and this is the time you can take out the patient's getting better. What happens to the column in this situation? Would the column keep on moving? There has been some misconception that the column has stopped moving. Can we take it out? Is it something that will happen, or the column will keep moving as long as the tube is in?
So what happens is that the column swing, as we call, depends on how much of difference in the pressure is occurring inside the chest with inspiration and expiration. Whenever you have lung fully expanded, there will be very little change in pressure during inspiration and expiration, and your column swing will be minimum. Whenever after lobectomy, if the remaining lobe does not expand and you still have a lot of space there, then that space leads to wide changes in pressure between inspiration and expiration, and then that leads to a wide swing. So if you are seeing a wide swing in the column, it means that there is some space is still present inside. But as I said, complete lung expansion, clinically, radiologically, no air leak for more than 24 hours, no blood, no fresh blood, no altered blood, no pus, and drainage between 100 to 200 cc. That is the time we will remove the chest tube.
One question has come up, and you also touched upon this aspect on your presentation. That was pleurodesis. So that's related to intercostal drainage as a bridge to pleurodesis in certain patients. I believe that most of the time it's thoracoscopic, but in some situations you do in the beginning you do intercostal drainage, and subsequently you go for pleurodesis. What is your regimen?
Yes, so pleurodesis, what you use and what regimen depends on the cause. Let's say malignant pleural effusion is one cause where we do it. So that the agents available vary from rubbing the pleura that we often do at the time of operation, especially thoracoscopic operations for pneumothorax, where the rubbed pleura, the abraded pleura, the lung gets adherent to that abraded pleura, to use of substances like tetracycline, which used to be available in the past, not available now, use of betadine, which pulmonologists are very fond of using, to use of talc. Now, talc gives you the best pleurodesis. But let me clarify one very fundamental point here. What is pleurodesis? Pleurodesis is symphysis or adhesion between the visceral and the parietal pleura. So what you do, you put in an agent or you do rubbing, which leads to abrasions on the parietal pleura, and when the lung is fully expanded, the visceral pleura is adherent, and that inflamed surfaces join each other, and that's how you get pleurodesis. So fundamental requirement for pleurodesis to be effective is lung to be expanded. This is a fundamental mistake done by a large number of people. Lung will be collapsed and they will put talc inside the chest. Oh, we have put talc to do pleurodesis. Friend, pleurodesis is adhesion between parietal and visceral pleura. If the two pleurae are not in contact with each other, no pleurodesis can take place. So what you do, I suppose there is a malignant pleural effusion, I put a chest tube, fluid drains out, lung expands. Now this is the time I can put talc slurry, talc mixed in saline, that can be put through the chest tube. It gets distributed across the chest. It will cause irritation. How does it work? It causes irritation and inflammation of the pleura. Inflamed pleura get adhered to each other. Whether you use talc, whether you use rubbing, whether you use betadine, or you use blood patch, whichever agent you use, the prerequisite is a fully expanded lung.
You initially evaluated that there is a free fluid, and you put in a tube the way you have described. And then at the end, you find that the free fluid has drained, but there is some pocket somewhere. So in this situation, when would you take a call about doing another aspiration or would you be okay with doing a thoracocentesis for that?
Sure.
So what will be your approach to such a situation where residual correction is?
Again, excellent question that you thought it was a diffuse generalized pleural effusion. You put a chest tube, majority of the fluid has got drained, but you have an isolated pocket remaining here and there. Now, what you do depends on the clinical situation. Suppose the patient had initially presented to you with breathlessness, etc. It was thought to be tubercular effusion. You've drained it, you've done ADA and other analysis, and you feel it's tubercular effusion. Now that you put the patient on ATT, patient is fine. If it's a small collection and the patient is doing well from, there is no fever, there's no rise in counts, it's not pus, it's not infected, and the patient has no respiratory problem because of that, you may even just decide to leave it alone and follow up the patient. But if it's a large pocket, if you think it's infected, if it's causing respiratory compromise, or there is some other associated issue, then I would go for an ultrasound guided, another separate pigtail or chest tube being put into this loculated effusion.
We are reaching towards the conclusion of this very pulsating session.
Is it 5:30?
No, we are reaching towards that. So we have a few more questions.
We have totally more than 65%.
Absolutely. So, what is the best this analgesic regime that you would recommend for this situation? Would NSAIDs be enough, or would you need to upgrade the analgesic?
Yeah, as a policy, I avoid using opioid analgesics in my patients because they make the patient drowsy, and I think keeping patient fully alert, awake, participating in the recovery is very important. Now, at the same time, you have to give adequate pain relief. So orally, we use a combination of paracetamol and ibuprofen. So one of the paracetamol ibuprofen combination is our starting point, and we would usually give them 3 times a day, post breakfast, post lunch, post dinner. This is what we start with. If we need to go to injectables, I have found diclofenac to be extremely potent injectable analgesic. Surprisingly, I don't know why, I've not found oral diclofenac to be that effective, but I have found injectable. So all my thoracoscopy patients actually in the post-op period get a mixture of injectable paracetamol because ibuprofen is not available in an injectable form. So in the immediate post-op period, they get a combination of injectable paracetamol and injectable diclofenac. And as soon as they are able to shift to orally, they go to paracetamol ibuprofen combination. But as I said, whether you use 1 agent or 2 agent or you supplement it with 3rd agent depends on the pain threshold of the patient. Sometimes when giving a combination of paracetamol or ibuprofen does not help, we add a fentanyl patch to these patients. So about 12.5 milligram of fentanyl patch put on the skin helps these patients. The only drawback of that I see in many patients is that a lot of patients have vomiting with that. So these are the combination. Of course, you have to be very careful with the diabetic patients, kidney disease patients, hypertensive patients, elderly patients. Their NSAIDs have to be used very carefully. So if we have anybody who's a long-term more than 20 years diabetic, hypertensive, has any history of kidney disease, we feel that kidneys could be in, or has a borderline 1.72 kind of a creatinine, we avoid diclofenac as well as ibuprofen completely. We use paracetamol, and then we use fentanyl in injectable or patch form in those patients. Usually, morphine, pethidine, I don't use. I have not used it for last 10-15 years.
Great. Regarding prophylactic chest.
Sorry, just one small point. We also use these gels, the local creams. Yeah. So the site around the chest tube, you can have diclofenac creams are available. Various combinations are available. So we also use a lot of local cream application for additive.
Prophylactic tube placement in severe chest trauma, where the patient doesn't actually have hemothorax or not a marked hemothorax, may be a candidate for intermittent positive pressure respiration. So what is your take on that, and how is it any different from the way you have explained it in your main presentation?
Sure. So, if there is no hemothorax, there is no pneumothorax, and patient is just to be put on ventilator because of, say, head injury, and patient has no problem at all, I don't put prophylactic chest tubes in that situation. However, there could be a situation where you have associated multiple rib fractures and maybe a minimal hemothorax.
Exactly, that's the situation.
Yeah, so that is a situation where if the patient is being put on positive pressure ventilation, it may be safer to put a chest tube on the side of multiple rib fractures. More important is, and this is something we see more often because most of these patients will have some or the other reason obvious to put a chest tube, that once you have put a chest tube, you don't remove chest tube in a patient who's still on ventilator or has a possibility of going on ventilator. So a patient who is on ventilator or may go on ventilator, even if he's meeting all other criteria for removal of the chest tube, you will hold on till the patient comes on spontaneous breathing. Reason, if this patient who's on ventilator has any amount of pneumothorax, it will be few minutes in which it will convert into tension. Therefore, you don't. And that is the reason why if the patient is on ventilator and has a chest tube and has any air leak, there is, clamping the tube is a big no banned, because you will immediately precipitate tension.
All right. This related to use of antimicrobials. How do you look at chest tube placement in terms of antimicrobial therapy? Do you look at it as something which is to be used only as a prophylactic, or do you think it has to be continued as an empirical therapy so that the patient doesn't develop infective complications?
Yeah, so I want to tell that antimicrobials are not a replacement for asepsis. And this is a very strong message I want to give to my resident colleagues, because there is a tendency developing amongst a lot of us that we will substitute asepsis with antimicrobials. Antimicrobials are not a substitute for asepsis. Asepsis is paramount. Of course, even with asepsis, there will be situations where you would use antimicrobials. So those are to be used. Now, what combination to use? Definitely, when you are putting a chest tube, you would like this patient to be on some antibiotics. If it's a community kind of a pleural effusion, patient is otherwise okay, then maybe something like amoxicillin clavulanic acid combination, some average level antibiotic would suffice. Of course, when you have ICU like situations, patients are having multiple problems, patients are on ventilator, patients are having chest infection, then according to the flora of your hospital, according to the flora and culture sensitivity of your hospital, of your ICU, and any culture grown from any of the other places, you will need to up the antibiotic based on those results. But more important message is asepsis is the most important.
How long can we keep
so
that?
Just one addition. So antibiotic is not for chest tube site infection. Antibiotics these people will be getting for concomitant associated other problems like chest infection, abdominal infection, bone injuries or other injuries. Those are more important.
So I think it's very clear message that you have given, that mere presence of chest tube is not an indication for antimicrobial therapy.
No. There
has to be some other condition
reason.
or other reason for it.
Yeah.
That's right.
But having ensured that you've taken aseptic precautions.
Absolutely. One more question. Yeah. That was related to open thoracostomy. And how long can you, first is, how long can you keep the tube? Would there be a time when you think that this tube has been present for a long enough time and I must change it? And when would you take a call that, okay, this patient now needs to be converted to an open thoracostomy treatment?
See, there is no upper limit for keeping the chest tube. It also depends on the reason why. So if you are needing a chest tube to be kept beyond a few weeks, there has to be a reason. So what would be the reason? you are probably having air leaking out. If air is leaking out, then it's an indication for intervention. So let's come to a situation called primary spontaneous pneumothorax or secondary spontaneous pneumothorax. Now these cases will present to you with pneumothorax, lung is collapsed, you put a chest tube, the lung expands. Now there are definite indications for intervention in these patients. When you put chest tube, in next 48-72 hours, your lungs should expand. If the lung expands completely, your air leak should stop in about 5 to 7 days time. Now, various international thoracic societies say that if your lung refuses to expand per primum after putting a chest tube, or it expands but your air leak continues beyond 7 to 10 days, then that's an indication for exploration, thoracoscopic or open, because then they will have a bleb or a bulla or something which is leaking out. This is in a situation of pneumothorax. Now, if you have, say, hemothorax and you have blood coming out for many weeks, that means there is some kind of a continuing bleeding there that needs to be explored. More often what we see is that there is a big hematoma, hemothorax which occurs. You put a chest tube, partly drainage occurs, the clots remain inside, and you have about 100-120 ml of dark brown fluid coming out. You do a CT, you will find that there is a big collection, residual collection inside. Then that collection needs to be drained. Another situation is chylothorax. You've got some chylous material, it keeps coming out. So if you are needing to keep the chest tube for beyond a few weeks, please look for the cause and address the cause. Continuing to keep the chest tube is not going to give you cure of the primary problem. The primary problem needs to be fixed.
Great. When do you think is thoracocentesis enough, and when does the thoracocentesis needs to be changed to an intercostal drainage?
Thoracocentesis
is simple aspiration.
Yeah. Well, that depends on the pathology. So when you have pneumothorax and it's less than 1/3 of your pleural cavity, patient is absolutely comfortable, then there are two options. One, you can just observe the patient, or some people will just do a one-time needle aspiration. But after that, if your air reaccumulates, then you go in for a chest tube insertion. But I would say that instead of needle aspiration, if you have a significant amount of pneumothorax, I think putting a small size chest tube is a safer option, because then after that you can sleep at peace. If you just aspirate, you would always have this possibility. If the air reaccumulates, I'll have to put a chest tube again. About the chest tube. So another thing is, if you have fluid, now coming to fluid, there is, if small amount of fluid is there, you do a diagnostic and therapeutic aspirate. Your fluid is completely drained. You do an ultrasound. You find there is no fluid. You send it for analysis. You start treatment accordingly. Few days later, you repeat. The patient is fine. There's no need for a chest tube. But this patient comes back at 48 hours. The whole fluid has reaccumulated. Now, at this stage, I have seen people reaspirating, and we've had patients having had 7, 8, 9, 10 times aspiration. Remember, every aspiration in radiology suite or wherever has a possibility of introducing infection. The more the number of aspirations, the more the chance of infection. So therefore, if any patient has been aspirated once and has reaccumulated and is again having fluid, I would go for a chest tube insertion, complete drainage, and keep the tube there for a few days. One time, single, careful chest tube insertion is safer, done properly, is safer than the risks associated with multiple aspiration being done. I hope I've answered.
Absolutely. I think you have answered questions in great details with a lot of passion, and really thank you very much for bringing in so much passion and energy into this presentation.
Have we reached 5:30?
Yes. So I think questions that we have received, we have tried to moderate them. So
I got the questions answered.
More than 65 questions, but sir has been kind to assimilate many of them.
Yeah.
Otherwise, it's impossible.
Yeah, that's his experience as a moderator.
Still, there may be a few questions, which may not have been answered. You are welcome to contact us on the number that we have given you, and through Healthium channel, you would receive the answers to these questions from Professor Arvind Kumar. I think it's been my singular pleasure to have moderated this session, And also I felt that probably if it had happened earlier in my career, I would have learned a few more things more exhaustively and would have been a better surgeon.
That's your modesty, sir.
Thank you, Professor Kumar, for a beautiful presentation. And I would now give it over to Professor Kumar for the final conclusion to this very wonderful program. And the next program in the series would be the next ASI webinar on 18th September 2019, and the speaker is Dr. Sarfaraz Beg from Kolkata, and the topic is best groin hernia repair, avoiding complication traps. And the Healthium channel and ASI would be reaching you with the link and the date and the time of the program. Thank you, and over to Professor.
So as we informed that every month, third Wednesday, 3:30 to 5 o'clock is the fixed day and time for the monthly webinar, which will be a routine activity in ASI now. As sir announced, next month will be by Dr. Sarfaraz Beg from Kolkata, who will be addressing you on a very important topic of groin hernia. So please remember to join us next month, third Wednesday, 3:30 to 5, and be in touch with your Healthium representatives. They are your friends, so be in touch with them and they'll be sending you the links by which you can join.